Welcome to the AstraCura Clinical Series, the Pathology of Brain Aneurysms. A cerebral aneurysm is a severe vascular defect that provides zero physical warning. In its unruptured state, it lacks symptoms that usually accompany neurological distress. The condition begins as a localized mechanical failure. When a weakened section of an arterial wall is subjected to persistent hemodynamic stress, it balloons outward into a thin-walled sac. This state is defined by clinical silence. Because the anomaly does not obstruct blood flow or immediately compress adjacent neural tissue, cognitive and motor functions remain entirely unaffected. This lack of early diagnostic markers renders traditional, symptom-based diagnosis ineffective. This clinical silence creates a significant barrier to preventative care. Without a symptomatic trigger, medical intervention is forced to be reactive, often occurring only after the vessel has failed. Clinical discovery typically follows one of two binary pathways: an incidental finding during unrelated testing or an emergent crisis. The incidental pathway occurs when a radiological scan, ordered for an unrelated condition, accidentally reveals the asymptomatic defect. The emergent pathway occurs when the aneurysm reaches its structural limit and ruptures, presenting instantly as a catastrophic brain attack. We will map this pathology from the initial radiological detection to the precise window of neurosurgical intervention. Understanding the timelines of these two pathways dictates whether the clinical approach can be curative or must focus on urgent damage control. Cerebral aneurysms typically form within the meninges, the three protective membranes surrounding the brain: the dura mater, the arachnoid mater, and the pia mater. Situated between the arachnoid and the pia mater is the subarachnoid space. This fluid-filled cavity serves as the primary corridor for the major cerebral arteries. If an aneurysm on one of these vessels fails, it triggers a hemorrhage directly into the subarachnoid spaces. This event causes an immediate spike in intracranial pressure, while the chemical composition of the pooled blood becomes toxic to the surrounding brain tissue. This specific hemorrhage is the physiological mechanism responsible for the sudden, severe symptoms associated with a brain attack. Once the emergent symptoms present, clinical confirmation requires immediate transition to neuroimaging. The primary goal of the initial scan is to identify the distinct pooling pattern of a subarachnoid hemorrhage. Radiologists and neurosurgeons must then locate the exact point of structural failure, which is often obscured by the pooled blood. They utilize specific structural markers to differentiate healthy vessel pathways from the abnormal ballooning of an aneurysmal sac. Identifying this exact radiologic signature before a rupture occurs provides a vital incidental finding, allowing for neurosurgical repair before the vessel fails. High-fidelity neuroimaging is the vital bridge separating a fatal hemorrhage from a targeted surgical treatment plan. A rupture is a high-risk event, and the initial outcomes can be severe. However, there is a critical clinical window that follows the initial bleed. Patients often experience a temporary stabilization phase after the initial hemorrhage clots. If the vessel is not repaired, the patient faces a secondary drop caused by a re-rupture. The neurosurgical objective during this window is to physically isolate the aneurysm from blood flow, preventing that secondary failure. If treatment is successfully executed during this stabilization phase, the patient has a high probability of a complete recovery and a normal life. Managing a ruptured aneurysm involves a direct race against a secondary, often fatal mechanical failure. Shifting from reactive emergency response to a preventative strategy requires a focus on genetic risk. Aneurysms are not strictly random. They possess documented familial and genetic linkages. This genetic link creates a clinical mandate for patients with a family history to undergo active neurovascular screening. When an unruptured aneurysm is identified, physicians monitor it for morphological changes. If the sac demonstrates growth, the risk of rupture increases. This growth serves as the threshold for action, allowing for prophylactic surgical intervention before a hemorrhage can occur. Rigorous genetic screening shifts the advantage to the physician, neutralizing the threat before the catastrophic subarachnoid event begins. This unimpeded vascular network represents the ultimate goal of neurosurgical intervention. The condition is defined by its dual nature, a silent structural defect that reveals itself only through imaging or acute trauma. Modern management relies on three clinical pillars: identifying incidental findings, executing rapid post-bleed interventions, and utilizing genetic screening protocols. Advanced radiological mapping and neurosurgical precision have established the brain attack as a diagnosable and potentially curable pathology. If you have a familial history of neurovascular events, seek a formal clinical assessment. Reach out to the specialists at AstraCura to discuss your screening and treatment options. Constant vigilance and the advancements in modern neurosurgery have successfully taken a historically fatal brain attack